Hi, my name is Lauren Marshall. I am a practice facilitator for the ROMPO project, Reframing Optimal Management of Pain and Opioids in Older Adults. And we are going to talk about shared decision making today in this podcast.
And I'm Dan Berlin. I am the PI on this project and going to turn it over to Lauren at this time.
All right. So one of the first questions that we want to ask ourselves, is what is shared decision making? Because it sounds really simple, but it's a little bit more complicated. It's actively engaging and empowering your patients to be participants in their own healthcare. And so it's moving the conversation a little bit more beyond just a dialogue and coming up with actionable steps and clear goals. So the meaning is very simple, but different. So I don't know, Dr. Berlin, do you want to talk a little bit about how is shared decision making, you're really leading the patient along the process rather than telling them?
Yeah, in this day and age, patient autonomy is emphasized and essential. On the other hand, if clinicians abdicate all of their ability to guide the patient to reach the correct decision, then we're not doing our job right. And so this is a way of educating the patient and then giving them the tools to make the right decision among limited choices.
Yeah, it seems like that's a really great opportunity to demonstrate you really care about your patient and that you're interested in their opinions and their values. And especially when we're talking about things where we're really wanting behavior change, it's necessary to have the patient buy-in. And so having those conversations, talking about those options is going to be your best way for the patient to really adhere to their care plan. And that includes medications and treatments. Dr. Berlin mentioned you don't always have that many options to choose from. And so it's about trying to vet your patient's preferences. So if we're talking about clinical options for medication, we might want to really consider the frequency, duration. Where does the medication need to be stored? Making sure that the patient sort of has those facilities at home if they need a refrigerator, if they don't have access to care, if they can't get to their appointments to take their labs, maybe there's a different med that they could be on.
And an essential thing to consider that is often forgotten is, will their insurance cover what you're intending to prescribe?
Yeah, how do you manage that when it's unreasonable for a provider to know what all of the insurance, coverage costs? Is there a way that you help your patients determine that, or somebody that you can refer them to help?
With practice experience, you learn very quickly, particularly with very limited coverages such as the Medicaid HMOs.
Right. And then with Medicare too, right? There's a bunch of different types of prescription coverage, and some patients might have supplemental plans, whereas others might just be straight Medicare, and that might impact what options they have. It's also a little bit interesting too when we're thinking about working with an older generation who may not have been included as much in the medical care decisions for the majority of their life. So this might be something that's new to them, and they might really value that. Building on that a little bit further, with an older adult population, there's going to be more significant co-occurring disorders and complicated medication management and treatment plans. So having a family member there as a patient representative can help with that. Do you have experience working with family representatives or patient advocates with your patients?
Yes, and sometimes you have to sort out the bias of the family member and the influence it has on the ultimate decisions that's made by their parent or whoever it is.
Yeah. If you're talking with the patient, you're getting to know their values and trying to understand where they're at in their own understanding of their disease. You might discover that there are some social determinants of health, like housing or rides to appointments that they don't have access to. And so having these conversations, asking them these questions might uncover that. And then you can refer them to some of the community resources. There's local agency areas on aging across the country that is going to be probably the best, most comprehensive place to look for those extra services and a way that you can sort of point them in the right direction. Let's talk a little bit about how do you actually implement this shared decision-making strategies within your current clinic workflows. So we don't want to reinvent the wheel. We don't want to give any more work to anybody really on the care team, whether that's at check-in, the MAs that are the nursing staff. So coming up with ways and processes that already build off the current workflows. Like maybe it's an appointment scheduling thing where you have to call the patient to get their confirmation. Maybe you use that as another opportunity to have some deeper discussions about their treatment options. How do you really incorporate that into your own clinic?
Well, you do the best you can given the limited amount of time. And so if the family member isn't there, then a phone call probably after the appointment is the best thing. You can't possibly do it during their limited time slot.
Yeah, you're definitely working within a short amount of time. So I think this is a good segue into maybe discussing a couple of your patients that you've had in your practice that show our listeners some of the ways that shared decision making has worked and give them a couple of case studies to understand this a little bit better.
So one of the cases is about giving bad news and leading a patient to the right decision about treatment. And the other one is about changing a patient's mind on what the right treatment would be after a long period of incorrect treatment. So the first case was a 63-year-old woman who actually presented to my service in the hospital with terrible epigastric pain that proved to be caused by pancreatic cancer metastatic to the liver with a huge mass diagnosed 3 months before elsewhere. And she was undergoing chemotherapy and had already had a follow-up CT scan that showed progression of her disease. So she now presented with a few days of severe pain. She had been taking Tylenol number 4, which would be approximately equivalent to Norco 10/325 tablets, and she was taking 8 a day for perhaps an 80 morphine equivalent dose per day. Socially, she was living alone in her newly acquired house, and she had excellent family social supports. On presentation, she was crying. She had a large liver mass. X-rays showed no clear evidence of obstruction, and the recent CT, as I said before, showed evidence that her masses were increasing despite her treatment. Her laboratories did not show signs of dehydration or electrolyte abnormalities. So the discussion that followed after stabilizing her pain situation by using IV PCA morphine, when she was far more comfortable, was then to proceed with a discussion about her understanding, or I should say lack of understanding, that she had been given about her disease by the treating doctors, its current status, its true prognosis, because this was really at a time where there was no chemotherapy. Now we have chemotherapies that can delay death for perhaps 6 months or so, and what options she reasonably had. So that was the information part for her. Obviously difficult for her to take, but we moved on pretty quickly to what her goals were, particularly for right now, which was obviously pain control, but returning to her home and how she would spend the end of her life. And so her goals were that she had just purchased this house and moved into it, and she loved it, and that was where she wanted to be. And if her treatment was futile and was not going to extend her quality of life and perhaps could shorten her life, she did not want to have any more chemotherapy. She was quickly converted to oral therapy and discharged to home hospice with the expectation that she would live perhaps 8 weeks, told to her. I managed her over the phone from that point on, and except for one dose adjustment that would be expected with the tolerance that people acquire to opioids, she was comfortable and actually died within 6 weeks. She, of course, expressed her gratefulness that she was able to make it home. So that was one case. The other case was a man who came to me as a new primary patient. He was 72, suffering from post-polio syndrome, which meant weakness and wheelchair use, who had a history of multi-level spinal fusion several decades before and had been on a home ventilator because of the post-polio syndrome, but mostly because of his high-dose opioid treatment that he had been treated with for a total of 30 to 40 years. So he had moved down from the Upper Peninsula to down here in Southeast Michigan because he could no longer live alone, and he had the opportunity to invest in a larger house for his daughter, who it turned out was now getting divorced. So he moved in with her into a situation of the daughter freaking out and terrible home stress, and the work necessary to get done to make him live there comfortably put on hold, which was a huge mess because of his disability and need for a ramp and wheelchair use. So over the preceding 30 years, he had been started on Darvocet, a common low-level treatment that when it was removed from the market was converted to Norco, a much more aggressive treatment, and gradually increased to not the largest dose that I'd ever seen anyway, at a total of 6 tablets a day or 60 morphine equivalents. He was also chronically treated with 2.5 milligrams of Valium for sleep, not a correct use of benzodiazepine, and certainly I think all doctors have known since 2016, the highly publicized CDC guideline, that opioids and benzos are not a great pair of drugs to give together, especially when you have respiratory insufficiency and use a home ventilator. So after some conversation with the patient, he said that he was doing reasonably well on his regimen, but not great, and he was afraid to change it and did not want to change it because this is the way he had been treated for all those decades. But my goal was to convert him to buprenorphine, knowing its safety profile, not necessarily less respiratory effect, but that he wouldn't suffer from further escalation of dosing and would actually probably be better off because I could push him to higher levels. And we also talked about removal from benzo, which he agreed to. So he was eventually switched to Belbuca and arrived at a dose of 300 micrograms twice a day, which worked great. But then his insurance coverage was cut off and he had to be switched to sublingual. And after some dose titration, he arrived at a dose of 2 milligrams 3 times a day of sublingual plain buprenorphine, doing very well, saying this was the best he had felt in more than a decade, and was thinking of volunteering for a political organization. So with him, it was a matter of working on his beliefs and convincing him that change could actually improve him. And he had the courage to go for it. Incidentally, he was easily removed from benzodiazepine, never missed it, and slept fine.
Wow, those are both really great examples of shared decision making in practice. One of the things that strikes me, especially about the first case that you shared, is how, as a primary care provider, you were able to sort of look at her situation from a higher point of view and take into account some factors where, a specialist might not be thinking about the whole picture, maybe thinking about their part of it. But that's a really important way that primary care providers can really move the patient along on a treatment plan that works. And with the second case that you shared, the man expressing fear over changing his medications, I can definitely empathize with that, and change is scary. And so coming up with a way where you can have those conversations to get him to the point where he's ready to change seemed to be pretty impactful.
So with the first one, I kind of had a dual role because by then I was already working pretty much as a pain doc as well. So that's why I was able to get her pain under control so quickly. Then that permitted an easy transition to a homegoing regimen. And of course, our discussion, it facilitated our discussion during what would be an acute phase. And I was a new person to her. So she didn't really have to believe anything that I said. In the case of the second one, he could have been a good example of a patient who would say, and I'm sure everybody's heard this, I know my body and I know what I need. And unfortunately, they may know their body, but they don't know where their decisions come from. And so they have to be exposed to additional possibilities after you've convinced them that you've heard them out.
Yeah, which seems like it's probably not always that easy. You probably face quite a bit of resistance when you first start out on those conversations.
That is true.
Well, great. Thank you so much, Dr. Berland. Please tune in to our next segment of our ROMPO podcast, which is going to talk specifically about the ARC Share Approach Model, which is a 5-step framework that you'll be able to use in your practice to really implement these changes. Hi, my name is Lauren Marshall. I'm a practice facilitator for the ROMPO project, Reframing Optimal Management of Pain and Opioids in Older Adults, which is a quality improvement project. In this part of our podcast, we're going to talk about the ARC Share Approach model, ARC being the Agency for Healthcare Research and Quality. They've produced a 5-step framework that will help you implement shared decision-making principles into your regular patient care. This is a longer training that essentially is made up of 5 modules that involves about 6 hours of training. I'm just going to be going through the bare bones, basic framework for their model. And if you're interested in learning more or actually going through with the full 6 hours of training, you can look it up on their website and they have links and everything that you would need to sign up for that. So the first step within the Share Approach model is seek your patient's participation. This is the S in their model. This is when you're going to want to remind your patients that them participating in their own care is important to you. You want to involve them in their care decisions whenever it's feasible and possible. So there are some things where they're not going to have a say, but there's other things where you're really going to want to loop them in order to help improve their care and adherence to care plans. This might look like inviting a family member or a caregiver, especially when we're talking about an older adult population. Can also work on your active listening skills and providing sort of small sections of information without jargon, which will again help the older adult population. The next letter in the model is H. Help your patients explore and compare treatment options. This is your opportunity to present them with the scientific facts, their evidence-based options. This might involve writing down the options in plain language so that the patient can review them later, bring them to other appointments they might have with other providers, or to loop in a family member who's going to be helping them. You're also going to want to focus on the risks and benefits of each of the options. You're going to want to explain the limitations and what would happen if the patient decides not to seek treatment, or what would happen with each of their treatment options that you present. This is a great opportunity to work on some skills like teaching back, which is a technique that you can use to check for understanding in your patient, where they're going to explain to you in their own words what they heard from you. And so this is a great way for you to evaluate if what you're saying is being delivered and received in the way that you're intending it, or if you need to clarify some things if the patient isn't understanding. There's some decision and learning aids that you might want to use in this situation, whether that is a pros and cons list of the different options, or even a visual model. This might be a great way for them to feel included in their care. And again, this is going to be where you're going to really focus on those evidence-based options and really encourage your patient not to seek the help on the internet, but to trust what you're providing them. You can use some of the tools that you already have available to do so. So the next letter in the model is A, assess patients' values and preferences. So talked about it a little bit already, but the best way for you to help your patient adhere to their care plans and to improve their conditions is really going to be by asking them what's important to them, evaluating what's most important for their own life and their own recovery, whether that's recovery time, maybe the cost of the medication or procedure, the level of pain they're in, the level of functionality that they're trying to achieve. And this is where you're going to want to try to agree with the patient on what's important. Ask them open-ended questions. Try to get to the root of what might be some barriers for improving the condition that you're monitoring. The next letter is going to be the R, and that is reach a decision with your patient. So this is going to be where you're trying to wrap it up. You've guided them through the process. You've told them that they're important and need to be included in their care. You've helped given them resources. You've helped assess their values, and now it's time to help them make the decision. So asking them questions like, Would you like any additional information? Do you need more time to think about this? Are you ready to make a choice? These kinds of questions are going to help compel them to make an informed decision at this point in their care. And our final letter is going to be E for evaluation of your patient's decisions. So as the provider, you are going to be responsible for checking back in on your patient for whatever medical conditions you're monitoring. That might look like doing a drug test if they're being prescribed opioids and you want to make sure that they're taking them. It might be going to referral appointments. It might be looking at their labs, ordering new labs. This is ways that you can help evaluate their care and then present to them where they're at in a way that they understand. One of the things that I think might be helpful at this point in the podcast is to run through a brief case study or example of a patient being walked through this process by their provider. So in this situation, the patient is a smoker. They're 65. They've been smoking for most of their life. Talking about quitting has come up in previous appointments. And so I'm going to be sharing an observation that I had of when I was able to view one of our providers and really walking through this model with their patient regarding smoking cessation. The patient and the provider had conversations about quitting before. And so this was a follow-up and really getting at assessing where the patient is now and where they're at in their desire to quit. Firstly, asking the patient if they're still interested in quitting, if they've tried anything in the time between you've seen them last, if they've have anything going on in their life that could impede or create a barrier on this. Then you're going to walk them through the options. And with smoking cessation, there are many options. You've got the patch, you've got the gum, you've got medication that patients can take that will help reduce their cravings and reliance on nicotine. You also have some behavioral tips, models that you can represent for them. So maybe that looks like having a lollipop after a meal, because that's a time when you would really be triggered to smoke. Walking them through those options of the tools that you have to offer that can help them quit smoking cigarettes, and assessing where the patient's at and their values. And so this is looking at their life in a little bit more of a bird's eye view. So what are the barriers that are going on right now in this patient's life that could impede their progress on quitting smoking? So asking, this provider really focused on asking the patient about their support system that they would need in order to be successful in this plan, which was mainly his wife. And so the provider was asking questions about, how's your wife doing? Are these things still going on at home? Do you think this is going to be a good time for her to help you out on this process? And he really took into consideration the other factors that are impacting somebody's desire to quit smoking or their inability at the time to do so. And then checking in with the patient at the end of that conversation to say, are you ready to make a change? Let's think of a date that you think is going to be your goal, and I will help you on that process. And so you've reached a decision at the end of the visit where the patient has decided, yes, I want to quit smoking. Right now, it's important for me and my wife to get through this situation we're going through. But at the end of the month, I think things will have calmed down enough for me to quit smoking cigarettes. And then the next step is going to be checking in with them at their next appointment, or sending them a message via the portal or a phone call just to see if they're having any troubles, if they need any more resources, checking in on them about their progress. Thank you for listening. And in our next section, we're going to be talking about motivational interviewing and how you can use that in your practice.
Greetings. My name is Latia Balkham, a practice facilitator at Altarum, and I want to talk to you today about the concept of motivational interviewing. When a patient is experiencing ambivalence, it can often be challenging to implement change. Here's when motivational interviewing can be helpful. Motivational interviewing, or MI, is often recommended as an evidence-based approach to behavior change. According to Miller and Rolnick, motivational interviewing is a collaborative, goal-oriented style of communication with particular attention to language of change. It is designed to strengthen personal motivation for the commitment and to a specific goal of eliciting and exploring the person's own reasons for change within an atmosphere of acceptance and compassion. Motivational interviewing is a guiding style of communication, and it encompasses good listening and giving information and advice. Motivational interviewing is designed to empower people to change by drawing out their own meaning and importance of the capacity for change. It is also based on respectful and curious ways to engage with a patient. It's important to note that motivational interviewing requires the clinician to engage with the patient as an equal partner and refrain from unsolicited advice, confronting, instructing, directing, or warning. While the principles and skills of motivational interviewing are useful in a wide range of conversations, it's particularly useful to help people examine their situation and opinions when the following are present. When ambivalence is high and people are stuck in mixed feelings about change, when their confidence is low and the people really doubt their ability to change, when their desire is low and they're uncertain about whether they want to even make the change, and also when their importance is low and the benefits of change and disadvantages of the current situation are high. Motivational interviewing has some core skills that we'll talk about. One of those skills are open questions. And this allows you to draw out and explore the person's experiences, their perspectives, and ideas. It also is about affirmation of strengths and efforts and past successes to help the person build up hope and confidence in their ability to change. Another part of MI is reflections. And those are based on careful listening and trying to understand what the patient is saying by repeating or rephrasing, even offering a deeper guess about what the person is trying to communicate. This is a foundational skill of motivational interviewing and how we truly express empathy. Summarizing, which ensures that we are understanding and reinforcing key points that are made by the client. And then attending to the language of change, which means that we're identifying with what is being said and creating that change talk where appropriate to encourage a movement away from sustained talk or that mindset that they're already in and gearing them more towards change. And lastly, exchanging of information, which respects both the clinician and the patient's expertise. Sharing information is considered a two-way street and needs to be responsive and respectful to what the client is saying. Additionally, motivational interviewing has 4 fundamental processes. The first is engaging. Again, this is the foundation of motivational interviewing, and the goal is to establish a productive working relationship through careful listening to understand and accurately reflect the person's experience and perspective. The second is focusing. And in this process, an agenda is negotiated that draws on both the client and the provider's expertise to agree on a shared purpose, which gives the clinician permission to move into a directional conversation about change. The third is planning. And planning really explores the how of change. This is where motivational interviewing's skills with the practitioner supports the person to consolidate commitment to change and develop a plan based on the person's own insights and expertise. And lastly, evoking. In this process, the clinician gently explores and helps the person to build their own why of change through eliciting the client's ideas and motivations.
Hi, my name is Carrie. I am one of the practice facilitators on the ROMPO project, and in that role, I work with practices on implementing the program recommendations. Today, Tia and I will enact a mock case study that demonstrates how providers might use motivational interviewing to engage a patient in exploring solutions to their healthcare concerns. In our case study, we have the patient, Catherine, who is 65 years old. She recently had surgery and as part of her recovery has been in physical therapy. She's otherwise a healthy woman. Catherine has been making progress in physical therapy, but struggles to complete the home exercises assigned to her by her physical therapist. She says that the exercises are uncomfortable and worries that she should be resting between visits. She also doesn't seem confident in her ability to do the exercises on her own. She is visiting her PCP today to address her slow progress and is anxious to, quote, get back to normal, unquote. The physical exam has not shown warmth or significant swelling, and she is sleeping okay. Her physical therapy visits seem to be going well. So why do we think motivational interviewing would be helpful in this situation and with this patient?
Motivational interviewing would be helpful in this scenario because we see the patient is ambivalent about doing the exercises on her own. We would want to encourage behavior change by helping the client accept, validate, and explore any issue that they are ambivalent about, and then help them to build motivation.
So in our role play today, we have Tia as the provider and I am the patient, Catherine. The provider's goals in this case are to reaffirm the importance of following the physical therapist's recommendations and stress that the home exercises are an important part of the recovery process and will help her get back to normal more quickly. Also, to offer options to address the patient's lack of motivation. Could she get someone, a friend or a family member's assistance? Is there someone available to support her and hold her accountable for making sure she does those exercises in between her physical therapy visits? And if so, how do we get them involved? Another option could be splitting up time spent on exercises throughout the day if that makes it easier to squeeze those exercises in. They don't all need to be done at once. So just helping her explore some different options that might overcome this resistance to doing her home exercises. Now we're moving into our role play.
Thanks for meeting with me today, Catherine. My name is Dr. Tia, and I understand our visit for today is to discuss how you're doing postoperatively. So tell me how you're feeling.
Well, definitely better. And I feel like I'm healing. It's just, it's going so slow. So I'm really getting frustrated that it's not closer to me being back to normal.
Well, it's good that you're feeling better, but it sounds like you're still concerned about not feeling at 100% yet. So tell me a little bit about how you're progressing with physical therapy.
I mean, it's going fine. The sessions are hard, but I always feel better than the last time. And I really like the therapist. Where I struggle is doing my at-home exercises.
I hear you saying that you like the progress that you're making with your physical therapist, but you're having some trouble completing the exercises at home by yourself. How would you like things to be different?
Well, I know I don't feel comfortable doing them on my own. I worry about things like what if I do it incorrectly or make things worse. Plus, it just feels like the sessions with the physical therapist are hard enough and my body needs some rest in between, right? So it would be nice to have maybe somebody to encourage me and make sure I do the exercises correctly.
Well, Catherine, I'm glad you're enjoying physical therapy with your therapist because going to physical therapy is part of the healing process, and it will also allow you to get back to normal faster. As for your home exercise program, I understand you want some support to ensure that you're doing things correctly. Do you have a family member or a friend that might be able to help?
Wow, I thought about that, but I didn't want to bother my daughter. But now that you mention it, if it would really help get me going on this, just having her there will perk me up, I think, and take my mind off of how much time it takes. I wonder if she'll know how to help me, though.
Well, what about having your daughter go with you to your next physical therapy appointment? And that way she'll be able to learn about your home exercise program and the ways that she can assist you. How does that sound?
That sounds like a great idea. I think I can ask her to help me out. She'd be willing to do that, I think. I feel better already.
That's great, Catherine. And I just want to make sure that we know what we're doing going forward so that you are going to take your daughter with you to your physical therapy appointment. And that way she'll have the ability and opportunity to learn about your home exercise program and ways that she can assist you.
Yes, that sounds great.
Great. Well, Catherine, I'm looking forward to hearing your progress. I want to see you in 2 weeks, and please call the office if you have any questions or concerns.
Okay, great. Thank you so much, Doctor.
You're welcome. Thanks. So we want to move forward into a debrief of what happened and how we were using motivational interviewing. And so we saw that Catherine, the patient, was ambivalent about doing her home exercise program because she felt like she really didn't have any support, or she was nervous or scared about doing the exercises wrong. And so what we did was really brainstorm with her about a friend or a family member that could help encourage her to do her home exercise program. And that way she can begin to feel comfortable and start healing and feeling back to that 100% that she wanted. And so in that, we brainstormed bringing her daughter with her to her physical therapy appointment to really learn about the home exercise program and how to assist her. And so Catherine was comfortable doing that. And as you see, it wasn't the provider who told her she had to do something. MI is really about being collaborative. And so the provider suggested that she bring her daughter or a family member, a friend, and the patient said, "Oh, my daughter. I think my daughter would make me feel good, and having that support would be helpful." And so that is really the purpose of motivational interviewing, is to really work with the patient and to really brainstorm ideas with how to make that patient's care better.
Great points, Tia. Motivational interviewing is a really important tool in shared decision making because it helps engage the patient. It helps build a relationship that's based on mutual respect and trust. And both motivational interviewing and shared decision making are patient centered methods that promote respecting autonomy, and both have been associated with improved patient outcomes. The strongest evidence for shared decision making comes from the use of decision support tools like motivational interviewing. So this concludes our segment on motivational interviewing. Next up, you will learn about ways that health information technology can help with the shared decision-making process.
Hi, my name is Lauren Marshall. I'm a practice facilitator for the ROMPO project, which is Reframing Optimal Management of Pain and Opioids in Older Adults, a Quality Improvement Project. In this portion of the podcast, we're going to be focusing on health information technology and how you can use that as a tool to boost shared decision making within your practice. So one of the tools that you can refer patients to is going to be the patient portal. In 2022, this is standard of care, and many of your patients are already going to be in the system. An older adult population, you might have a few more stragglers than you would see in a younger population. And so providing them multiple means that they can go and create an account, access their portal, and what the functionality within it is. I know in the beginning, when the portal basically first came out, a lot of health systems were providing patients with a printout, which had either a QR code or instructions for how to create an account with a temporary password, a username, and all of that, so that the patient was able to quickly reference and proceed with downloading that app to their phone. If you're not able to do that, you can still put signs up in the patient rooms with a QR code again, which the patient can just take their smartphone and hover it over with their camera open. Doesn't even have to take a photo, but can just hover it over that QR code, which would then trigger the download of the app on their smartphone. If the patient is really uncomfortable with technology, if there's anybody at your office that has a spare minute, maybe an MA has an extra second, or somebody on the front desk staff, either at check-in or check-out, has an extra minute to walk through the process with the patient, and show them the functionality so that by the time they leave your office, you know that they've created an account, they've already logged in, and that they know how to use it. Within that, one of the things that you're probably going to want to use is secure messages. This allows you to communicate with your patient in a timely and convenient manner, especially in this world of virtual care. Secure messages need to be monitored and need to be triaged, but they can really be a great tool for boosting that communication and stressing the importance of the patient's participation in their care. Another thing that the portal can do, which I find really helpful, is the patient education resources. And for myself as a patient, I had an experience with a provider where I had multiple conditions that I was trying to manage, and she gave me a bunch of different ideas and a bunch of different resources and printed them out and handed them to me, which was great. You know, they have the pictures and all of that. However, I will most likely lose those papers, or I'll file them away and I'll never look at them again. And so I had to ask my provider if she could send those to me via my portal so that anytime I want to access them, I can. I can go log in. I know exactly where they are. I know that they're all going to be there. And it's just a really good way for you to keep your education materials in one place so that you can actually use them. Smartphones are pretty standard. However, older adults, again, may not have this. And so this is an opportunity to teach them about the proxy and how they could have a family member that also has access to their patient portal. Other apps on the smartphones too are going to be good ways to help your patient with shared decision making. There might be a behavior tracker that you want to, share with your patient, and then they share back with you so that you're able to, in the meantime, between appointments, communicate, ask them questions, and follow their progress. Also, things like disease management apps, whether that's something that manages your blood pressure, your diabetes, things of that nature. It's a great way to record things. Again, have it all in one place, and then you can easily reference it in the future. The patient can bring you their phone and just show you what's been going on rather than trying to have them explain it all separately. Another thing that you may not have thought of, because primarily you're working with the EHR in terms of clinical care. You're doing your notes, you're processing the encounters, and you're really having to pay attention to all of the little details that you as a provider are going to be entering. Some of the functionality within the EHR, like tracking labs and tests over time, can be something that you might want to flip your screen, share that image with your patient. So this, again, I have a personal patient example for this. I was working on a specific health condition with my provider, and we had a plan and we were monitoring it over time. And she was able to track my progress over the course of the year and show me in the graph or in the chart form where my levels are. So for me, it was showing that I was improving. Others, it might not show that. It might show that they're stagnant or that they're actually declining in their care for that specific condition. And sharing that screen with the patient sometimes is giving that visual cue that can really help make it sink into them what they need to do to help improve their care. As an older adult population is less likely to use technology and be comfortable with technology, it's important to acknowledge those barriers and help patients out on an individual basis. So some patients won't ever log into a portal, and that's fine. You can still use some tools to help them with shared decision making. So if they have a smartphone, if they have a phone that you can do a recording on, you can record them explaining the process or the situation back to you. And then when they are confused or they have questions, they can just re-listen to that recording, hear their own voice, hear your voice, and not have any more questions because you covered it all in that recording. And they can go back to that as many times as they are interested in. EHRs are here to stay. There are barriers and there are complications involved in it, but it's a great tool that you might want to consider using in a different way to incorporate your patient into that shared decision-making role within their care. In our next section, we are going to wrap everything up for this podcast and complete the shared decision-making portion. I'm Lauren Marshall, practice facilitator for the ROMPO project.
And I'm Dan Berlin, and we are back.
We are back, yes, to wrap up our shared decision-making podcast. So in this podcast, you've learned some approaches that can benefit your patients, improve health outcomes and quality of life, and increase adherence to care plans. Dr. Berland, is there any other thing that people want to be mindful of when we're working with an older adult population?
Well, I think it goes without saying that since dementia creeps into the lives of many elderly, good care means we have to be aware of it and occasionally even go back and screen for it, because obviously you can't hold discussions like this with somebody who's slipped greatly. And it's important at that point then to have a caregiver, a family member, or other representative there with, so that a meaningful outcome occurs after the discussion.
Yeah, that's very true. Well, thank you. In this podcast, you started out learning a little bit about what shared decision-making is and why it's important. And then we moved into learning the framework that ARC provided, the SHARE approach, as well as some strategies like motivational interviewing that can help you on these discussions. And we finished with some ways that health information technology can empower your patients. This is the end of our podcast. If you're interested in learning more about our program and looking through some of the resources and materials we've put together, you can visit our website at altarum.org/ROMPO, and ROMPO in that case is capitalized. You can also send us an email at rompo@altarum.org if you have any questions. Thank you for spending some time with us and learning about shared decision making.
Thank you.